So, hello everyone, a very good evening to all of you. I welcome you to all of you in the Ophthalmology Instruments session. Um, this was a much awaited session, and I must say, this is really important. And this is important for every student, because as far as your ward leavings are concerned, your vivas are concerned, you are always, worried about your instruments part. Secondly, nowadays, they are asking more questions on the practical aspect. So, in that matter, also, more and more instrumentation is asked. And last but not the least, when you are reading about the surgeries, in the theory per se, whether you are reading it for your prof exams or you are reading for your entrance exams, actually if you do not know that particular instrument, now it becomes slightly cumbersome to understand the surgery. On the other hand, if you are well versed with the instrument, its usage, it becomes very easy for all of you to understand it. So I hope my audio video is clear. Is my audio video clear to everyone, guys? So we will be covering the instrument in both ways. First of all, we'll be doing the identification part, and then we will be trying to cover its usage also. Now, as always, we will be doing it in the interactive way, so that we are actually discussing the things and you get to know. You will also be revising these instruments, whatever we have already done in the classes. So we will be having a quick discussion, and I think that will be a mini revision kind of all of the ophthalmology, because surgeries and the instruments will be with respect to maximum topics. So I hope my audio video is clear. Can anybody guess which is this instrument? It has a first angle at a distance of. Now, first of all, I am showing you the questions, that what sort of questions actually can be asked on the instruments, and then actually I will be discussing it for you. Can you tell me what instrument is this, guys? Anybody? We are waiting just for a couple of seconds so that people can join in. Yeah. So second is this instrument, and then we have something like this. So they can ask you, identify the instrument. Is it an enucleation spoon? We have a evisceration scoop, lacrimal probe, or is it the entropion clamp? Then fourth is this one. These all things look very similar. We have a IOL dialer, a punctum dilator, a iris repositor, a Bauman's probe. Then is this instrument. This is again very important one, which has been asked many times. This was asked in August 2020 paper, AIMS paper also. This instrument is used in SICS or phacoemulsification, the ICCE or ECCE. Angle in the side port. What is the angle in the side port? We have a side port blade, we have a main blade. What is the angle in the side port blade? Hi, good evening to everyone. Which of the following is not used in DCR? Which of the following is not used in DCR? Is it a trephine? Is it a chisel? A bone punch or a punctum dilator? Which is not used? In a Calazion clamp, ring is applied. Hi, good evening. Calazion clamp ring is applied on which side? Is it the skin side or is it the conjunctival side? Hi Pooja, good evening. Which of the following will be used to do the PI? Is it iris repositor, a Kalman-McPherson forceps, a wire rectus, or a De-Wecker scissors? And what is this? It is used for all except we have the corneal diameters, horizontal iris diameters, PPV. What is PPV? And then we have the pterygium. So something like this sort of questions, because nowadays they are even giving you the MCQ type of paper in your prof exams also. Recently what they have, they are doing 80% of the questions are subjective and 20% of your questions are the objective type. So, I think it is especially very, very important for FMGs, because somehow, exposure is little less, and but when they are being asked, they are asked the same way. So the thing is that a sound knowledge of these instruments is really important, whether I talk about the FMG examination, NEET examination, or the prof examinations and the viva voce. And this is a glimpse of certain patterns where they can ask you these kind of instruments question. All right, so we will be doing this. Okay, so let's get started. We will be starting with the very basic instrument first, which is actually the baseline of all the surgeries. What is this? Can you name this? So that will again increase your benefit of the session if you go on actually commenting in the live chat. What is this? What is this, Pooja? What is this? Can you see? This is actually a eye speculum. So this speculum is called as the universal eye speculum. This speculum is actually called as the universal eye speculum. Now, why it is called as universal? Because it can be used for both the eyes. You can use it for the right eye also. You can use it for the left eye also. And speculum means for opening the eye. So, where will you use it? See, for every surgery and for any surgery for which I actually need the exposure, opening of the eye. Starting from hi Webab. So basically whenever you are doing any surgery, right from your destructive procedures, when I am doing the enucleation or we are doing the evisceration, we actually require the wide opening of the eye. So basically with the help of this speculum, we are actually widening the palpebral aperture. Now when you are doing this enucleation or the evisceration, what is happening? If you look at the basic steps, first of all, what is the difference between the enucleation and evisceration? We will also discuss the related viva voce questions. When they are giving you the speculum and you are saying that this can be used for the destructive procedures, it could be enucleation or evisceration, they are going to ask you what is the difference between enucleation and evisceration. So evisceration, that means you are just removing the viscera. We are just cutting a corneal button, or we can give a opening into the sclera, and we are scooping out the contents of the eyeball out, and then you can place an artificial ball implant into the eyeball and we can close the corneal button. So it is something like this. That is actually called as evisceration. So basically in cases of evisceration, the sclera is spared. We are not removing the sclera. Sclera is spared. While when I talk about the enucleation, we are removing whole of the eyeball. We are removing whole of the eyeball along with a part of optic nerve. So I will be telling you about the instruments also, that there is a difference in the instruments also, what we are using for the enucleation and the instruments that we are using for the evisceration. They are again different. Then second, a very important thing is the removal of foreign body. This is a very common complaint in day-to-day OPD practice also, and especially in this kind of weather when we have got now the this gritty sensation, too much of windy kind of climate is there. So the incidence of the corneal foreign bodies and the conjunctival foreign bodies is very high. And as soon as the foreign body is going, we can have a blepharospasm, we can have grittiness, too much of rubbing can be there, watering can be there. So obviously you have to remove the foreign body at the earliest. Now, one thing is that you have to remove these foreign bodies under the operating microscopes, or you could be removing these foreign bodies on the slit lamp. Now, sometimes what we are doing when we are removing them on the slit lamps, we are actually, exposing the eye, everting the eyelids with the help of our fingers. But many a times it becomes difficult when the patient is not cooperative and you want to stabilize your hand removing the foreign bodies. So that time also, especially when the patient is lying supine in front of the microscope, you can actually use these speculums. And as I told you, the advantage of this speculum is that they are universal eye speculum. So both the eyes could be used. You do not require a separate one for the right eye and for the left eye, and you can easily remove the foreign body. Third important thing is your cauterization of the ulcers. See, corneal ulcers is again a very important topic, and again you should be well prepared to give any answer over the corneal ulcers. Especially when I am talking about corneal ulcers, I am talking about the infective corneal ulcers. Basically, I am talking about infective corneal ulcers, and which infection is actually most common. It is the bacterial infection, and that is your Staph aureus. So in cases of the corneal ulcers, when you require cauterization, when you require the debridement, maybe the non-healing ulcers are there, then in those cases also you require the eye speculums in order to do all these procedures for all the intraocular as well as the extraocular surgeries. For all the intraocular as well as the extraocular surgeries also, actually we require the speculum so that we have the wide visualization of the eyeball. You have to give the limbal incision in cases of the intraocular surgeries. So for the intraocular surgeries, for the extraocular surgeries, for all sort, we actually require this eye speculum. So I hope this is very clear what is the use. Now the second important thing is this one. See, what is this? First of all, we have to actually find out, we have to learn how to identify, is it a forceps or is it a scissors? Okay, or is it a speculum? So for that you can see the shape. So you can see actually this is a forceps. So you know that this is actually a forceps. Now for giving the name of that forceps, basically you have to see the tip of that forceps. Don't have to name it by the handle. Okay, don't ever do this mistake. Look at the tip, because handles can be different in the different models. But if you want to give a proper answer, then you always have to look at the tip. Now can you see this tip? It is actually S-shaped. This is your S-shaped tip. Anybody who can answer this question? This is S-shaped tipped forceps. Then what is the name of this forceps? Vaibhav, Pooja, Prasant, Gurjar, anybody who can tell me what is the name of this? So S for S, you have to remember S for S, this is superior rectus holding forceps, because superior rectus you have to hold, you have to go in a curvy linear fashion. That is why the tip is actually given in the S shaped manner. So basically this is a superior rectus. It is actually a superior rectus holding forceps. Now when you have to actually hold this superior rectus, the superior rectus which is having a double curvature for a proper gripping of the superior rectus, and it is also containing a single tooth. A single tooth is there so that we do not miss the grip of the superior rectus. Now the other important question is that at what distance we are actually getting the curve. What is the first angle? The distance at which we are going to get the first angle. So always remember that when you learn your rectus muscles, we always remember the mnemonic mills. This is actually the distance at which these rectus muscles are getting inserted. So we have medial rectus, then we have inferior rectus, lateral rectus, and then we have superior rectus. So in the increasing order, it is 5.5, then 6.5, 6.9, and then 7.7. So superior rectus is actually having the farthest distance from the limbus, because its distance is farthest from the limbus, 7.7. that is why its first angle is at a distance of 7.7. So the mnemonic that you learn for the insertion of the rectus muscles will help you there also. So wherever you are actually requiring, holding of the superior rectus in cases of the squint surgeries, even when we are doing the cataract surgeries, we are passing the superior rectus bridle sutures. Then in that case also we require superior rectus holding forceps. So it is a forceps, it is S shaped. S is for superior rectus. Superior rectus is the farthest one from the limbus. So that will give you the distance of 7.7 mm. That will give you a distance of 7.7 mm. I hope this is clear, guys. Are you getting this? Then we come to the next one. The next one is this. Now see this is actually not a forceps. You can look at its shape. This is showing you the cutting blades. So cutting blades is actually a scissor. So this instrument is actually a scissor. Now can you see this is not a normal scissor? Yes, Alia, right. So this is not a cutting scissor. Basically, can you see we have got the V-shaped tip. So it is actually something like this. A V is formed and it will be cutting something like this. This is actually the spring action. This action is called as a spring action, and due to this spring action, this is actually your conjunctival spring scissors. Wherever we require, this. Hi Chitranjan. So this is actually require wherever you require, enormous cutting. So when we do actually evisceration and enucleation, I have to cut the conjunctiva, something like this. I have to cut the conjunctiva all around the cornea. For that, I require the spring action. Because of that spring action, this is called as the conjunctival spring scissors, right? It's basically a scissor which is cutting the conjunctiva, and that spring action is leading to the spring scissors, and usually we are cutting this conjunctiva in the enucleation and the evisceration. Now enucleation and evisceration differences we have already done. Then I will show you the instruments that are required for that also, and then we will be discussing the indications and the contraindications where you should do enucleation and where we should avoid this. Okay, that is other thing. So I hope this is very, very clear. Now see this. Another instrument is this. So this is again a forceps. You can see this is a forceps. So first of all, you have to look at whole of the instrument to see whether it is a scissor or it's a forceps, and then you have to look at its tip to see what it is trying to do. So can you see it is something like this, holding the hands kind of a thing. So it is an instrument which is actually required for holding something. We are holding it like this. Okay, if you have seen on the Earth Day also, we have got this kind of figures in by hands. We are holding the globe. So it is something like that only. It is actually holding the globe, because Hi Alia, is this instrument session enough for ophthalmics for FMG exam? Hi Alia. Alia, it is not for the opthal images. Opthal images is a wider perspective. This is all for the opthal instrument. So for the opthal instruments, it is actually sufficient. Image based session I will be doing next week. So for that, please attend. Okay. So this is actually your globe holding or the globe fixation forceps. Which globe? That means I am talking about the eyeball. So because it has to hold the eyeball and it will slip over. So this has actually 2 to 3 teeth, we can say 2 or 3 or maybe 4 also. We have got lot of teeth which are required for holding the globe, for stabilization of the globe, that is required. Plus whenever we are holding this, it is required for holding the conjunctiva and the cornea, because if this is the globe, we are coming it, so it will be holding the conjunctiva as well as the corneal tissue together. So this globe fixation forceps will be required whenever we are holding the globe, when we are making a sclerocorneal tunnel in cases of the SICS surgery, because when you have to make a sclerocorneal tunnel, we require to fixate the globe, because every time you are making the tunnel, if this globe will also move, you will not be able to do so. So in order to make that sclerocorneal tunnel, we will fixate the globe. And second thing, when you have to make the conjunctival flap in the next step also. So if you see, we are actually going towards the steps of the cataract surgery. We have used the eye speculum, then we have used that superior rectus bridle suture. Then you have to make the corneoscleral tunnel with the help of this. You can also make the conjunctival flap with the help of this globe fixation forceps. So for that also we require this globe fixation forceps, right? Now see this. This is the easy one. You can see the electrical wire. So because electrical wire is seen, so that it is something related to the electric. And can you see, this is again holding. So this is actually your electric cautery. This is again an instrument which is required for the cataract surgery. See, once you have given the limbal incision, you have made the tunnel, you are making the conjunctival flap. Now conjunctiva is a vascular tissue. Because it's a vascular tissue, we can have bleeding. Sometimes we have irregular incision, sometimes we have got irregular bleeding, sometimes we have lot of bleeding. Why we have lot of bleeding? Maybe the patient is having hypertension, or maybe a patient is having the heart diseases. So in all those patients who are having heart diseases, uncontrolled hypertension, we can have lot of bleeding. Otherwise eye is a cool surgery. We do not see usually lot of blood shedding around, but this is one thing where we can expect lot of bleeding, and that is why we do never surgeries in the uncontrolled hypertension or the heart diseases, because there you can have one. So this is your electric cautery, which is actually used for the hemostasis. And if you want, I will share this PDF afterwards on the Telegram group also, because this is again a very important session, and I want you everybody to give the right answer on the instrument. So just before your exams, you can look at this session, and you can use the PDF also to revise it, guys. So this is actually your diathermy. Diathermy is usually used to cauterize the vessels once you are making the flap. So I hope this is very clear. I think identification is not a problem. Yes, Aman is also there. Exactly. This is your cautery, and I think here your identification is not a problem. You can easily identify that this is your cautery. Then a very easy one. I think this is the first instrument that you get exposed when you come to the MBBS. MBBS first prof you are coming, and the first instrument that you are holding is a scalpel. So this is the scalpel that you are looking in the DH, along with the blade with which you start with your dissection on the cadaver. So this is your the normal one, the normal scalpel that we are using for the dissection in the cadavers also, and afterwards wherever you have to give the incision, these incisions you are giving for the cataract surgeries also, different kind of limbal incisions we are giving. Every time you have to give the incision, you have to use the scalpel and the different kinds of blades we are using. Who will tell me which number blade we are actually using, which number blade we are most of the time using for giving the incision? Anybody? Chitranjan, Alia, Aman, which number blade we are actually using? You have to use this scalpel and the blade in almost all the surgeries wherever we are doing the cutting. It can be it can be the entropion surgeries. Entropion, what is entropion? Entropion is your inward turning. Whenever we have got the inward turning, if we have the inward turning of the lid margins, or we have the outward turning of the lid margins, outward turning of the lid margins. And what is ptosis? Ptosis is the drooping of the upper lid, drooping of the upper lid there also. Or we are doing the DCR surgeries. What we are doing in DCR surgeries, we are actually creating the opening. So here we are creating the opening between the lacrimal sac and the middle meatus. This is again important. Normally the NLD is actually opening in the inferior meatus, but here this will be opening in the middle meatus. So in all these, when you make the sclerocorneal gutter, the sclerocorneal tunnel also in the cataract surgeries, everywhere you require blade. So which number blade? Number 15 blade we are using. Scalpel and 15 number blade we are using in all the surgeries. Alright. Yes, Aman is correct. Very good. So it's a 15 number blade. ठीक है? समझ में आ रहा है? Please keep on answering also, so that you get to know, confidence आएगा that you are able to identify. अभी ये देखो, another kind of similar one, एक और है the blade and the knife. So this is also there. Can you see? लेकिन the tip here is slightly different. So you are having a crescent shape, because we are having the crescent shape edge here. So this is actually called as the crescent knife. Crescent knife. Now you must have noticed this, that in many textbooks they are using interchangeably. Sometimes they are calling it as a crescent knife, sometimes they are calling it as a keratome. But actually crescent knife and a keratome are two different entities. When you are having knife something like this is called as a crescent knife. Keratome is actually a diamond shape. So when I am having the blade something like this is actually called as a keratome. Then this is actually called as a keratome, while crescent shaped knife may end is crescentic only. The end is crescentic only for the crescent shape. Blunt होगा, and this is actually a very important instrument. इसमें क्या है? We have got a crescent shape. So this is an ideal tool for making a sclerocorneal tunnel while I am doing the SICS. While I am doing SICS means we are having the small incision cataract surgery. Small incision cataract surgery. Now our professors also used to say it as tunnel incision cataract surgery, like TICS. Because here you are preparing, you are going to create a tunnel, a sclerocorneal tunnel. So this is the ideal instrument that we are using for SICS. While you will see that keratome we will be using for the phacoemulsification. Now who is going to tell me the incision size? What is the incision size? Because when you will be asked about these instruments, these are the related questions which they are going to ask you. What will be the incision size in SICS? They can ask you the incision size in ICCE. Then we have got ECCE. Then we have got SICS. And then we have got the phaco. phacoemulsification. What will be the incision size of ICCE, ECCE, then we have SICS, and then we have phaco. So for ICCE, because this is the oldest one, largest incision 10 to 12 mm we are using. Then ECCE mein we are going with 7 to 8 mm. SICS mein even smaller, so it is 5 to 7 mm. And finally phaco is 3 to 3.5 mm. So you can note down this. This is again a very very important question. Maximum times they are asking you the incision size and what are the advantages and disadvantages also. What are the advantages and disadvantages of your different surgeries, that also. Okay. So now coming to the next one that I was talking about. Now can you see, this is another handle with a blade. Handle with a blade, but here the blade is something like this. So this is actually your crescent shape. This is your diamond shape. So this instrument is your keratome. This instrument is actually the keratome, and this angle is 45 degree. This is a keratome having the tip and the angle is 45 degree. What is the use? This is actually used for the main incision in cases of the phacoemulsification. Now maximum times what we are doing, exactly what we are doing in cases of the phacoemulsification, if this is the eye, actually we are giving the two incision. One is this one and one is this one. This is your main incision and this is the side port. So maximum times in cases of the phacoemulsification we are actually using two. Now this will help you in solving the other questions also, FMGs. If you look here, this will help you in solving the other questions also. This main incision is actually given by the keratome. This is actually given by a keratome. Keratome is having an angle of 45 degree, the main incision, while the side port is given by the side port blade. So this side port blade is having an angle of 15 degree. So how many incisions do we give? What is main incision? What is the side port? The two angles and the name of their instruments. We have keratome and we have got the side port blade. Both are separate. We have a keratome also and we have a side port blade also. That is again there. So this is actually required for, making a entry into the anterior chamber. When you are making a tunnel and then you are making an entry into the anterior chamber, actually we are using this keratome. Okay. Then coming to this one. What is this, guys? This is a small instrument which is called as cystitome. Is this color visible here? This is called as cystitome. Now this cystitome is a very very small instrument. It is just having bent needle in the front. It is just used for giving the capsulotomy. It is having a bent tip at the end. So cystitome is actually used for capsulotomy. Which capsulotomy do we do? It is the anterior capsulotomy. Now this is again very very important question, especially for the FMGE exam. This question has even come in 2021 also in your INI-CT. So we are getting questions related to the instruments also. So in order to reach to the lens, we actually have to create an opening in the anterior capsule. Now this opening that we are creating in the anterior capsule, this is done with the help of cystitome. So first question which they ask is, what is the name of the dye that we are using? The name of the dye, anybody who will answer, what is the name of that dye that we are using for the anterior capsulotomy? Exactly, anterior capsulotomy. And what is the name of the dye that we are using? Can you see? I have made a color also. because capsule is transparent. So until and unless it is actually colored, you will not be able to see what is there. So we are using a dye here, so that it is colored, and then it is colored here also. Then it is colored here. We are using a dye. Anybody who can tell me what is the color, the name of the dye that we are using? Now there are two techniques of capsulotomy that we are doing. One is your circular curvilinear capsulorhexis. This is the first one that we are doing, and the second is your can opener technique. So the bent tip of this needle is used to do this creation of the opening in the anterior capsule, called as anterior capsulotomy. Have you given me the name of the dye? Anybody? Exactly. Here is also blue color used. Hi Ganesh. So yes Ganesh, you are right. The name of the dye is your trepan blue. It is the trepan blue color that we are using, and actually we can do the anterior capsulotomy by two techniques. One is your circular curvilinear. So what we are going to do, with the help of this bent tip, I am going to give an incision in the center, and then I will take it to the periphery, okay, and I will extend this in a circular curvilinear fashion, something like this, in a circular curvilinear fashion. So when you are giving the opening in the center, you are taking it to the periphery, and then we are going to move in a circular fashion. This is how we are going to remove the anterior capsule. This is called as the anterior capsulotomy by circular curvilinear method. While second is your can opener technique. So what we are going to do, we have something like this. We give the opening in the periphery, and then we are going to remove in the reverse fashion. So it will go something like this and something like this backward. So in this way we are going to remove it, similar to how we open our cans of the soft drinks and all. So that is your can opener technique. Both the ways we can do with the help of these techniques. And sometimes we don't have the cystotomes. This is a very small instrument, so even you can do desi jugaad. We have got that 18 gauge needle that is always there. So you, with the help of forceps, you can just bend the tip of that needle, and then also you can use it in the form of the cystitome. So this is the question related to that, and the dye also. Is it clear, guys? Then we have got the next one. Now see this. Again you can see that this instrument is actually the forceps. You can see, and in order to give the name of the forceps, this is actually the tip of the forceps. So this tip, can you see, it is something like this. So if I make it something something like this also, it will go into a K. So this is actually Kalman-McPherson forceps. एक तो था, that was S shaped, तो S वाला तो था SR, superior rectus holding forceps, and जिसमें tilted है, तो that is resembling the K. So that is actually your Kalman-McPherson forceps. Now forceps you can easily identify. देख के you can see whether it is a scissor, whether it's a forceps, or whether it is a speculum. When you have to give the name, look at the tip. जिसमें scissor है and a V shape cutting is there, then that is your conjunctival spring scissor. ठीक है. जिसमें we had a S shaped one, that was your S shaped superior rectus holding forceps. If it is something like this, then it's a globe holding. If it is having the electrical point also, then it was a electrical cautery. Similarly, जिसमें slanting है, then this is a Kalman-McPherson forceps. So Kalman-McPherson forceps, can you see, we have got a blunt tip. So this is actually a bent blade. Sometimes it can be used to tear that anterior capsule also. I told you na, cystitome is the specific instrument that is used for the anterior capsulotomy. But if you do not have it, we can use the needle also, and we can use this Kalman-McPherson forceps also instead of that. So that is one thing. Second thing, in order to hold the IOLs, now when you are taking the IOLs means the intraocular lenses, you have very less space, and from that very less space through the AC you have to take the IOL. So you require something curved to take it inside. So for that curve, actually we use this Kalman-McPherson forceps. Secondly, for suturing, when you have to hold that needle, in cases of eye, the needles are curved, they are something like this, you have to take it like this. So you cannot use a straight forceps because it is like curved. So for that also we require this Kalman-McPherson forceps. So as an alternate for the anterior capsulotomy you can use. Then for holding the IOLs we can use, and for holding the suture tying के लिए भी इसको हम use कर सकते हैं, because eye is a surgery where the working space is very very less. What was the depth of anterior chamber? Anterior chamber depth is just 2.5 mm. So basically you have to work on this joint, just on the wrist joint. You have very very less space to work through it. So I require some small amount of curve in order to go inside, whether it's a IOL or it's a suture tying. Is it clear, guys? Right? Now see, what is this? Can you see? This is your L-shaped instrument. So one was K-shaped, one was S-shaped, and then this is L-shaped. L for L, this is your lens expressor. So this is your lens expressor. When you have already done hydrodissection, hydrodelineation, and we have to just express the lens. So what you are doing, you are actually applying the pressure at 6 o'clock. You are actually standing on 12 o'clock because you are standing on the head end of the patient. So this will be your 12 o'clock and this will be 6 o'clock. And if this is your lens expressor, so you are putting the pressure over the 6 o'clock, and just like a hockey stick, you are actually expressing the lens. Sometimes it can be used in place of the muscle hook also. It can be used in place of the muscle hook. Muscle hook may we have got a tip also. So they can be used interchangeably also, but if you have a tip, then that is a muscle hook. If it does not have this tip, then it is actually this lens expressor. So L for L याद रखो, K for Kalman-McPherson forceps, and S वाला tip का was superior rectus holding forceps. So I hope this is very very clear. ठीक है. Then this is another instrument. See this. This is your handle, and this is a kind of loop that we are going. So this instrument is called as wire rectus. This instrument is called as wire rectus. Now wire rectus can be of two types. It could be simple also, and we can have a hair connection with the irrigating cannula also. If you are having the connection with this irrigating cannula, then this is called as the irrigation wire rectus. Irrigation wire rectus. Then this is called as irrigation wire rectus. So what is the function of the wire rectus? Again, this loop is used to remove the nucleus or for the nucleus delivery. Like lens expressor was also used for the nucleus delivery, this wire rectus is also used for the nucleus delivery. Now the difference is that lens expressor was used at 6 o'clock directly for the nucleus delivery like this. But this wire rectus pe we are putting the counter pressure. So counter pressure will be done at 12 o'clock. So when I am putting the pressure at 12 o'clock, it will actually eject the nucleus at 6 o'clock. So this is actually the function of wire rectus. How wire rectus and the lens expressor are different, that is also clear to you, right? Then see, this is a very very simple instrument. Who is going to tell me? I think this is the favorite instrument. When you are lost somewhere in the tray, and examiner luckily says that acha, pick one instrument of your choice, then actually we are going to pick this. This is what? This is actually Simcoe's. This is Simcoe's two-way irrigation irrigation and the aspiration. Irrigation and the aspiration cannula is there. So this is two-way irrigation and aspiration cannula. If you see, we have given the incision also. We have done the anterior capsulotomy. We have made a tunnel. We have made an entry, hydrodissection, hydrodelineation. We have done. So then we have to aspirate that cortical matter, because the lens diameter, if you talk about the lens diameter, it is actually 9 to 10 mm. But what incision we are giving is very, very small in cases of phaco. How much you are giving? It is just 3 to 3.5 mm. So obviously you have to first disintegrate the lens, otherwise this 9 to 10 mm lens cannot come out through a very small incision, just 3 to 3.5 mm. So I will first disintegrate the lens, then I will dissolve it in the irrigating solution. So for that only we had given two incision. One was the main incision through which I am doing the phacoemulsification, and another was the side port through which we are doing the hydrodissection and hydrodelineation. We are injecting the irrigating solution. What is the best irrigating fluid? Now another question that could be asked, what is the best irrigating fluid? What is the best irrigating fluid that one can use? Please answer. So for the irrigation and aspiration of the cortical matter, so that we can put the IOL, how will you put? With the help of Kalman-McPherson forceps. How will you do the nucleus delivery? With the help of the lens expressor and the wire vectors. Okay? So for that we are going to use this irrigation and aspiration cannula. Anybody who has answered? What is the best one? Very good, Ganesh. Sai Gaurav. Aman, which is the best irrigating fluid that you are going to use? It is actually the basal salt solution. Basal salt solution with the glutathione. Glutathione is an antioxidant. That is why the best one is the basal salt solution with the glutathione. The basal salt solution with the glutathione. Now sometimes there is one more indication. Very good. No. Balanced salt solution is correct, but along with the glutathione, because it is the antioxidant. Now sometimes apart from this irrigation and aspiration of the cortical matter, what is the other indication that we can use it for? We can also use it for the AC wash, for removing the blood. When you have lot of hyphema, that is the blood in anterior chamber. So if you have lot of hyphema, so even for aspiration of that blood from the anterior chamber, for doing the AC washout, also we can use this irrigation and aspiration cannula. But always remember, whenever you are being asked anything, any cause or indications, or they are asking you the use, then first you have to give the most common one. Even if you are giving only one, but that is the most common, that will fetch you marks. But if you give 9 other uses which are not that important, the examiner will not be satisfied with your answer. So that is very, very important. Basal salt solution with the glutathione. Alright, now coming to the next one. Now see, this is again a forceps. And can you see, it is something like this. So this is your lens holding forceps, and it is something like this, which is blunt, because it is not injuring. It is not injuring the lens, because when you have to take the IOL, like we were using the Kalman-McPherson forceps for holding the IOL. Similarly, we can use this one also. This is actually for the non-foldables with the rigid one piece IOLs. Rigid one piece IOL. When we are using it for the rigid one, for holding the rigid one piece IOLs, usually we are using this lens holding forceps, which are made up of the PMMA, polymethoxymethaacrylate. And because you are holding the IOLs, they will not have tooth. Can you see? They will not have any tooth. You have to give it blunt, We cannot give the sharp also, and we cannot give the pointed tip also, right? So yes, it looks like a whale mouth. So it is giving a curve so that it can hold it. Because if we are holding it like this, so when you are taking it inside, it can touch that tunnel. That is why it is like this, so that when you are going it inside, it remains in the air. So that is why it looks like whale mouth. Okay, now the next one. Now once you have taken the IOL inside and you are putting the IOL, okay. Now you have to dial the IOL, dialer. So dialer mein kya hoga? Can you see? It is like this, then it is like this, and a beak is there. This is, do you remember the old telephones in which we used to dial the numbers? We used to do the finger something like this, and then we used to dial it. It is something like this. If you look at the IOL is like this, okay. Now you have to place the IOL just in the center. You have to work on its fixation. So it will have two dialing holes. It will have the two dialing holes. So we will hook this pointed tip in this dialing hole, and we will try to dial it so that we are bringing it in the center. So for the central fixation of the IOLs, we are using these IOL dialers. We are actually using these IOL dialers in order to bring them in the center. This is called as IOL dialer. Okay. Right. Then we have got this one. What is this? This is a very common instrument that we are using in cases of the DCR surgery. दोनों ही T shape है, ठीक है? So what you have to remember, T for trephine. This is actually the trephine which is used in the DCR surgery. T shape है, T for trephine. Now we have got two types of trephine. One is this and one is this. One is the pointed trephine and another is the blunt. One is the pointed and another is a blunt. Now P for P, the pointed is your primary trephine and the blunt is your B. दूसरे पे आता है A and B. This is second. So this is your secondary trephine. P for P, pointed is your primary and B second number पे आता है. So this is your secondary. So when I am actually trying to make the opening between the lacrimal sac and the middle meatus, when I am trying to make a opening between the lacrimal sac and the middle meatus, first I will have to mark where I have to create a opening. देखा है जब हम कील ठोकते हैं तो पहले एक निशान लगाते हैं. वो निशान किससे लगाएंगे? With this pointed one. So in order to make a mark where you have to create the opening, and then you actually kneel at the same place. So this is actually for making the opening. So you are marking with the help of the primary and you are making the opening by the secondary trephine. So trephine is actually used in the DCR surgery. What is a DCR surgery? At what age you are doing the DCR surgery? What are the indications and contraindications of DCR surgery? What is the normal lacrimal apparatus like? It is opening in the inferior meatus. What is the length of the NLD? It is 15 to 18 mm. What is the direction of NLD? Downward, outward and backward. These are again the common questions that could be asked in relation to the DCR. Then it depends upon in which direction your YY is going. They can go on the congenital dacryocystitis. So if I talk about the congenital dacryocystitis, this is again very important, especially for the FMG. Every year, they are asking some question on dacryocystitis treatment. So always remember, the first thing is 0 to 1 year. So whenever we are actually, treating this congenital dacryocystitis and baby is coming within first year, the first thing that we are going to do is the lacrimal sac massage. The first thing that we are going to do is the lacrimal sac massage, and this massage is also called as the Krigler's massage. the first thing that we are going to do is the lacrimal sac massage, which is also called as the Krigler's massage. Along with this, we give the topical antibiotics. You know, maximum times we have got the secondary bacterial infection also. So we are going to give the topical antibiotics, and believe me, about 70 to 80% of the people actually will get the spontaneous resolution. They will get the spontaneous resolution. Baby will get corrected only with the massage only. Then second thing, if they are not improving, then between 1 to 2 years actually we can start with the syringing. So syringing we are doing with the normal saline. Syringing we are doing by the normal saline. So you know, the membranous occlusion of the NLD. The NLD occlusion that was done by the valve of Heisner. That occlusion was done by the valve of Heisner. You try to open it with the help of the syringing, and if it is not getting corrected even now, then between 2 to 3 years we can even do the probing also. So this probing is actually done with the help of the Bowman's lacrimal probe. This we do with the help of the Bowman's lacrimal probe. You are taking from the upper punctum inside, or you are going through the lower punctum, and you can open that. Then number 4, if it is between 3 to 4 years and it is still not getting corrected, then you can do syringing and probing alternate. Then alternatively we can try for the syringing and probing, because you know, DCR surgeries usually we are not doing before 4 years. So it is only after 4 years of age that you can start with your DCR surgery. So this is how we are treating the cases of the congenital dacryocystitis. Okay. Then coming to the next one. Now this is again an instrument that we are using in the DCR. Can you see? This is an instrument which is resembling your punching machine that is used for punching the papers also. So this is actually punch. This punch is actually used for cutting of the bone. So this is a bone punch, and its full name is your Sitelli's bone punch. So when you are creating a opening in the DCR, okay, you have to cut the lacrimal bone. So when you are cutting the lacrimal bone and you are making the opening between the sac and you know, the middle meatus, you are using this bone punch. You are cutting the lacrimal bone. You are actually cutting the lacrimal bone. So this gives you, you know, a very carpenter like feeling, and you will get a crackling sound also of cutting the wood, and you know, you require a lot of energy also. It is always said that while doing the DCR surgeries, you require a lot of energy. Plus, you know, whenever we are doing the dacryocystitis, usually it is towards the evening, because a DCR patient is an infected person. So you will not operate it at the first incidence. First you will finish off all the cataract surgeries and all, and then towards the evening we are taking these infected cases. So surgeons are already exhausted and it requires a lot of pressure. So this is one instrument that is, you know, is not a kind of delicate instrument that you usually expect in ophthalmology. Sitelli's bone punch for the cutting of the lacrimal bone, that is there. Then yeah, now you know, whenever we are doing any surgery on the lacrimal apparatus, we have to first dilate the punctum. So basically we can dilate the punctum with this punctum dilator. We have to dilate the punctum with the help of this punctum dilator, so that any instrument that you want to take inside can easily go. So this is a simple one. You can see a conical tip also. This is your punctum dilator. this punctum dilator, before especially you have to take the probe, so I require the punctums to be very very patent one. So you can dilate it with the help of the, like in OBG you use the Higgards dilator. Similarly here we use this punctum dilator to dilate the punctum, so that is also there. Okay. Now I was talking about probe. We are doing the probing with the help of a probe. So this is your Bowman's lacrimal probe that I was saying now. This is your Bowman's lacrimal probe. So these are the instruments that we are using in the DCR surgery. Syringing तो you are doing with the normal saline. Then probing से पहले you are using the punctum dilator. Then you are doing the DCR surgery. DCR surgery के लिए we are using the Siteli's bone punch for the cutting of the bone. So that also we have done. Acha, two more things I wanted to show you, which are really really important. We were talking about the destructive procedures, so we will be talking about enucleation spoon and the evisceration one also. See this. When I can see something like this, see this is your handle and this is a spoon with this kind of gap. So what is this? This is actually the this is the enucleation spoon. So whatever instrument looks like, you can call it as that only. This is a spoon with the optic nerve guide. This is the enucleation spoon with the optic nerve guide. Now why do I require it? Because when I am doing the enucleation, I have to remove whole of the eyeball. So if this is the eyeball, something like this, then we have got the optic nerve coming out. So we are actually using this spoon, something like this, for hooking this optic nerve. We have to hook this optic nerve guide in this optic nerve, and then you can remove the eyeball. So this is your enucleation spoon with the optic nerve guide, while the other one is this. Here again you have a handle, but you have a small curate like thing. This is your evisceration. This is your evisceration scoop. So scoop mein what you are doing, you are first making a cutting above and then you are scooping out the contents of the eyeball. This is called as the evisceration scoop or a evisceration curate. So that is the difference between a enucleation spoon with the optic nerve guide and this is your evisceration scoop. A much smaller scoop is also there, then that is a Calazion scoop. Ab difference bhi to dekho, ek taraf you have a eyeball 24 mm and then we have a small Calazion. So Calazion ke liye we have a small scoop and evisceration ke liye we have got a large one. So that is their probe. You have seen punctum dilator, we have seen, see this, a much smaller, like this is there. Then this is your Calazion scoop. Calazion scoop है या फिर evisceration scoop है. Always remember about ice cream scoop. Ice cream निकालते हैं ice cream scoop से. Similar is the instrument. अगर छोटा है then it is a Calazion scoop and if it is a larger then it is a evisceration scoop. ठीक है. Dialers we have seen. Now this is one instrument which is a very sleek one. This is a handle that is there and then you have got two L's. Ek taraf se it is something like this and on the other side it is like this. So it's a very very sleek instrument, very delicate instrument. This is called as the iris repositor. This is actually called as a iris repositor. So as the name indicates, it is working over the iris, so it has to be very very delicate. Repositor means it can be used in the cases of the iris prolapse. Now you already know that we can have one of the complications of the cataract surgery, the iris prolapse can be there. So if the iris has prolapsed, you can actually reposit it back. Or if you are working on some foreign body of the iris, then also we can actually use, if there is any foreign body of the iris, or you want to break the Synechiae is there over the iris, then also we can use this iris repositor. Lens expressor bhi humne padha, punctum dilator was there, squint muscle hooks was there, and this is your iris repositor. Two-way irrigation aspiration, cannula, wire vectors you have seen. Now see, this is your Calazion clamp. One was your Calazion scoop. Now before giving the incision, you have to stabilize the Calazion. So for stabilizing, we have got actually the two rings. Now one ring is your solid ring, something like this. One is the solid one and one is the hollow one here. So you have to stabilize it. Once it is stabilized, you will do the cutting. So this is actually used on the skin side, while this is used on the conjunctiva side. This is used on the conjunctiva side. So this is again, you could be asked that which is your skin side and which side is used on the conjunctiva. The solid one you will use on the skin, and the hollow ring will be used over the conjunctiva. When you are stabilizing, over that you are using the cutting. So that is your Calazion clamp. And then yeah, see this. This is one another scissors, which is again having a small V-shaped type of configuration. This is your De-Weckers. This is your De-Weckers scissors. This De-Weckers scissors again has a spring action. तो V बनता है. V हम कहाँ बनाते हैं? In cases of PI. So whenever you are giving, optic in the iris, and you are doing it with the help of the surgery. FMG examination, again, this is very important. They have asked this many times, that where you are doing the laser iridotomy or where you are doing the surgical PI, which laser will be used. So when we are doing it surgically, which instrument we are using, because we are creating that V-shaped incision, we are using the De-Weckers scissors. So basically it is used for iridectomy or the opening in the iris, right? Yeah. Now see, I was telling you that similar to the lens expressor, we have one more instrument. So see, this is again your muscle hook. The only difference is that it has got just a blunt tip, because it has to handle with the muscles. So when you are doing the squint surgeries, then basically we are using the squint hook. But sometimes if you do not have, we can use them in exchanging manner also. You can use the muscle hook in place of the lens expressor, and vice versa also. So with this, we have come up to the end of the session. Femto. No, Ganesh, we are not using the femto for the laser iridotomy. For the laser iridotomy, we are using the Andiag. Andiag laser, which is 1064 nanometer. And the mechanism of action here is your photo disruption. The mechanism of action that we are using for creating the opening is actually the photo disruption. So now we will quickly try to do the questions on the basis of the session. Now you will give the answers. It has a first angle at a distance of. Yeah. So what is this? This is actually your superior rectus holding forceps. Because this is a superior rectus holding forceps, so it has a first angle that is present at a distance of 7.7 mm. This is the first question. Exactly. Right answer is 7.7. Now look at the second one. What is this? This is your cystitome. This is the cystitome. Now can you tell me what is the answer here? It is used for suture tying, anterior capsulotomy, holding the IUL or the nucleus delivery. What is the answer? Cystitome was used for the anterior capsulotomy. We discussed the dye also and the two techniques, the circular curvilinear capsulorhexis as well as the other one was your canopner technique. Coming to the next one, we have just discussed this. What is this instrument? This instrument is used in the enucleation for holding the optic nerve also. So this is actually your enucleation spoon. The full name is enucleation spoon with the optic nerve guide. Enucleation spoon with the optic nerve guide. This is actually the enucleation spoon with the optic nerve guide. Exactly. Question number 4. What is this? This is used for the iris. You can see the two ends here. So this is actually your iris repositor. IOL dialer मैंने दिखाया था. That was having the bent tip. Punctum dilator will be having the conical tip, pointed tip, something like this. Bowman's lacrimal probe was there, something like this. IOL dialer was having a small beak like area. So this is actually, yes, so this is actually your iris repositor. ये देखो, what is this? You can see this is actually your diamond shape. So diamond shape where the angle is 45 degree. This is a keratome. So this instrument is actually a keratome, and keratome is used in the phacoemulsification. This instrument is used in the phacoemulsification. What is the angle in the side port? Angle in the side port. Side port blade is something like this. I told you keratome was having 45 degree while the side port is having the 15 degree. So answer to this question will be 15 degree. Next question, which of the following is not used in the DCR surgery? Which of the following is not used in the DCR surgery?